Aloha, everyone. Thanks so much for joining me on this webinar focused on mammogram disparities. I hope everyone has been keeping safe during these difficult times. I also want to especially thank Dr. Scott Grosskreutz, President of the Hawaii Radiological Society, his entire team, and the ACR Commission for Women and Diversity for inviting me to speak today about my personal mammogram screening journey, my work on mammogram equity, and a review of the flawed U.S. Preventive Services Task Force mammogram guidelines. These guidelines suggesting that all average-risk women begin screening at age 50 racially disadvantaged minorities, Blacks, Asians, and Hispanics, whose breast cancer diagnoses typically peaks much earlier in the 40s. And so by ignoring critical race data for minorities, these guidelines create a deep injustice for these ethnic groups. All the references and data that I'm discussing today can be found in my most recent article, Systemic Racism in Mammogram Guidelines, published in Think Global Health. And all this to say, I'm truly honored to be here with you today, healthy and well, thanks to annual screenings in the 40s. 2018, though, for me was a completely different story. Shortly after the new year, most of my resolutions turned into background noise as I focused instead on prayer while undergoing several tests and reviewing concerning results stemming from an abnormal routine mammogram screening. My family was shaken. My younger daughter, just a middle schooler in 8th grade, and my older teenager home from college slept with me every night for the first few days, worried that our expected lifetime together was becoming very uncertain. And my husband of almost 22 years not only showered me with the utmost love and care, but also being a physician, helped me navigate difficult choices with compassion and dignity. Because after all, a woman in her 40s deserves every chance to make choices that allow her to live life to the fullest, a quality life to the fullest. We are often in energetic roles as moms, wives, workers, and community members. We're not elderly. We're in the midst of our lives, often with dependent children. Consequently, my family will always remember the start of 2018 as the time Mom thankfully dodged breast cancer. However, to this day, I'm deeply haunted by how close I came to making the wrong decision that year, and how it would have deprived me of that chance to become a breast cancer dodger. During my annual physical, my PCP had tried to explain to me that for a woman in her 40s with no family history, no lifestyle risk factors, no palpable lump, and a clear mammogram the year before, there was absolutely no reason for me to get a mammogram done again, especially since the new US Task Force guidelines recommend that women like myself should wait several years until age 50 to even begin screening. And yet, feeling on the fence with this advice, I'm really glad that at the end, I decided to act on a strong inner premonition, an indication which I felt needed for me to have a mammogram one more time at least. And so my PCP ultimately deferred to my wish, and I had a 3D mammogram, which produces even better detection in dense breast tissue, which is often present in 40% of women, particularly slim ones like myself who have not yet gone through menopause. And then a few weeks later, my family, friends, and community were shocked when I shared my stage 0 precancer diagnosis. Visible only as a tiny microscopic scratch on a screen. And a comparison to my prior year mammogram confirmed that this was definitely a new development. Unlike true cancers, stages 1 through 4, at stage 0, abnormal precancer cells have no developmental capacity to move or invade into surrounding tissue yet. So the timing of this catch was crucial. And one good outcome of sharing my very private results was that many of my acquaintances went immediately for their own mammogram screenings. Suddenly, I was a case in point for all of them about why leading cancer institutions like MD Anderson and Sloan Memorial Kettering, along with organizations like the American Society of Breast Surgeons and the ACR, all recommend Mammograms start at age 40 and continue annually because new abnormal tissue changes can often occur in just 1 year. And because stage 0 is a precancer, this stage is not reflected in true invasive breast cancer, which is stages 1 through 4. And those statistics remind us that actually a jarring 1 in 6 true breast cancers occurs in the 40s. 1 in 8 women gets afflicted in her lifetime, and a 75% majority have no family history or any high-risk factors whatsoever. In my case, I went for a 28 gene panel test, and everything came back normal. So it's really important to remember that the vast majority of people do not have family history and do not have high risk factors. And yet stage 0 remains perhaps the most important early diagnosis opportunity, offering women the unique chance to dodge stages 1 through 4 invasive breast cancer entirely, with the least harsh treatment options, including surgical routes that do not require subsequent chemotherapy, radiation, or long-term daily drug usage. Never before had I been so relieved to achieve a 0 on a test. And thanks to annual mammogram screenings, I'm truly lucky to identify and count myself as someone who is a breast cancer dodger rather than a breast cancer survivor. And then, of course, I had to make sense of this journey. I had to ask, how could someone in her 40s with no family history, no lifestyle risk factors, and a clear mammogram just the year before even be diagnosed with a precancer? I wondered if my outcome was not an uncommon one. And if so, how could the task force have revised their guidelines to encourage all average risk women to wait till they turn 50 to start screenings, and to even start those just biannually, knowing that abnormal tissue changes often do occur in just 1 year. So annual mammograms are important. And what were the cost and policy implications here? Seeking answers, I turned to the areas that I have trained in best: data, finance, and policy. And in parsing through websites, testimonials, research papers, and archived government documents, I found myself uncovering a much deeper message that needs to be shared and articulated from a racial injustice perspective. And that is that the task force guidelines to start mammograms at age 50 are racially unjust because they disproportionately disadvantage minority women in their 40s. According to a major Harvard study, unlike white women whose breast cancer diagnoses typically peaks in the 60s, breast cancer diagnoses amongst Black, Asian, and Hispanic women peaks in the 40s. And so to begin mammogram screening at age 50 is just far too late for these racial groups. I created a visual graphic to explain this simply. And it shows that a start at 50 U.S. Preventive Services Task Force mammogram guideline approach leaves minorities behind. It's also important to remember that a significant 23% of all white women's breast cancers are diagnosed in the 40s. So the new guidelines approach just does not make sense. It not only devalues women during the midst of their lives, but is racially unjust because it fails to account for ethnic differences in age-related breast cancer data. And yet the task force, in pushing for its start at 50 case, has used fallacious arguments by misapplying 4 key concepts. And these are worth looking at together: overdiagnosis, false positives, mortality, and cost. So, first of all, the task force places far too much emphasis on overdiagnosis, a concept which creates this uplifting notion that treatment may not be needed for all cancers, since autopsies do occasionally discover previously unknown asymptomatic breast cancers that would have never affected a person's life otherwise. And while this may be very true for a slow-growing cancer in a really elderly person nearing the end of her life expectancy, it is totally irresponsible to suggest that precancers and cancers can be left untreated in the 40s because of overdiagnosis, since breast cancers in younger women often tend to be more aggressive. Therefore, overdiagnosis is a completely hollow argument in the 40s, and missing a potentially aggressive malignancy can have devastating life expectancy consequences for this age group. Secondly, the task force uses an argument of false positives, a term referring to suspected lesions in mammograms that subsequently proved to be benign upon further testing. The task force identifies false positives as a principal harm, implying that mammograms are somewhat dangerous and not valuable because they could be wrong. And yet, interestingly, in reality, 87% of all mammogram findings are accurate. Additionally, 3D mammograms have a 40% better detection rate than even regular mammograms, making them really useful, as I'd mentioned before, for women in their 40s who may have dense breast tissue. And then thirdly, by primarily emphasizing mortality data, the task force guidelines lose focus on critical quality of life improvements possible by catching an abnormality early enough at stage 0 to dodge harsher treatments, disfiguring surgeries, and debilitating side effects that chronically overwhelm patients, both emotionally and physically. You don't need to be a scientist to understand that catching an abnormality at stage 1 versus stage 4 will have vastly different quality of life implications. After all, 2 women at different stages of cancer could theoretically live equally long lives, but at what quality of life cost to them? Arguably, a woman who is diagnosed at an earlier stage and undergoes short, easier treatments can move on and enjoy a high-quality life like her peers, compared to a peer who has lived just as long but endured years of debilitating, harsher treatments for a later stage cancer catch. So for minorities, the new delayed screening approach not only means getting diagnosed later at a more advanced stage, but also means potentially enduring a far lower quality of life while alive. And lastly, but perhaps most importantly, the task force claims that its final recommendations were made without cost considerations. And yet, until recently, their website mentioned that in a final modeling report intended to help clinicians, employers, and policymakers, 20 strategies were compared to select the most efficient approach. And a new intervention was deemed more efficient if it resulted in gains in health outcomes while consuming fewer resources or costs. This content has recently been removed from its website. However, the original cost intent can still be uncovered by reviewing a published U.S. Preventive Services Task Force recommendation statement, which reiterates that the most efficient screening strategies were actually informed using a CISNET study. And then if you go to that CISNET study, that explains that 20 different strategies were explored, and again, only those that improved health outcomes while consuming fewer resources or costs were deemed efficient. So that word efficient there is being used very carefully, and costs were definitely considered in the detailed planning. And what this means for minorities is that if the task force guidelines become approved law, the new Start at 50 mammogram screening approach would allow insurance companies to potentially no longer provide annual mammogram screenings at age 40 as part of preventive care. And this would create an enormous conflict of interest, an enormous conflict of health interests, because eliminating screening benefits in the 40s would not only raise the out-of-pocket costs shouldered by ethnic patients whose breast cancer diagnosis peaks in the 40s, but also would then discourage them because of the expense to get the screenings when they need them the most. Consequently, for all these reasons we just discussed, annual mammogram literacy amongst minorities is really crucial so that women in their 40s are not blindsided by the task force screening recommendations, and so that they can have more informed discussions with their own physicians about real health choices. Based on my own advocacy efforts through minority seminars, I found that only a concerning 48% of attendees realized that malignant tissue changes can occur in just 1 year in a healthy person. And after my seminar, I'm glad that 83% of them understood the importance of an annual mammogram for a healthy person with no family history. And most importantly, 97% of them felt it was crucial for them, for minorities, for women, to have a chance to get diagnosed early at stage 0 precancer, to dodge stage 1 invasive cancer. Minorities deserve that equal opportunity to be diagnosed as early as possible. And yet, the task force patronizingly emphasizes that diagnostic testing induces anxiety. And yes, going through the testing that I did was stressful, but the task force neglects to explain that this anxiety and stress is fairly minimal compared to the subsequent stress that would be endured by ignoring an area that turns out to be a precancer or cancer. Minority women in the 40s cannot be pacified through ignorance and deserve every opportunity to treat their disease at the earliest. As a South Asian woman who was not high risk, I shudder at the thought of how badly my family would have suffered had I waited several years till age 50 for my next mammogram. Thankfully, I did not. And I have been able to enjoy life, a quality life, as a result. I have been blessed to raise my daughters, watch my younger one graduate from middle school that year, and start high school. I enjoyed buying her the promised puppy she wanted for so long after we went through everything we did as a family. And I enjoyed my older one's college graduation and start of medical school. And last week, I celebrated a milestone anniversary with my husband. As for 2018, looking back, even though it had started off with its challenges, it also counts as one of my favorite years because I felt so grateful for having dodged a really serious health crisis. And of course, my family went to celebrate to Hawaii. And being there, celebrating my recovery, we snorkeled, hiked, and swam with the manta rays. Participating in such lively activities is what being an energetic woman in her 40s is often all about. I'm so thankful that I'm actually here at a conference hosted by the Hawaii Radiological Society, because Hawaii will always be very special to me. Ultimately, when we learn together, we do better for each other and for our communities. I leave you with a few key points. Annual mammograms in the 40s are especially critical for minorities whose breast cancer diagnosis peaks in the 40s. So women should not be confused by the new unjust task force guidelines that blanketly ask all average risk women to wait till age 50 to begin screening. We should also remember that 23% of all white women's breast cancers are also diagnosed in the 40s. And together, we need to advocate for annual screenings and their access for all women as part of our preventive care in the 40s so that our mothers, our wives, our daughters, our women might have the same chance that I did. The chance to become a breast cancer dodger rather than a breast cancer survivor. Thank you so much for having me here today. Mahalo.